Good afternoon, everyone. Are we all set?
Good afternoon.
Good afternoon. Good afternoon, madam.
Good afternoon.
Hello, Dr. Ash.
Good afternoon, sir. Good afternoon.
Good afternoon. Dr. Kapoor is yet not joined.
Yes.
Okay.
He is joined, I think. He's there.
He is joined only.
He's
That person is not there, Rajarao.
Yeah. So it's only we six, those who are present right now. So it's going to be like a personal discussion.
No, not like that. Audience, we can't view, no. It's only faculty link, we are there. But otherwise, people will be there in the audience link.
Okay.
They can't enter here.
So we have to make this session slightly interesting. And it is a wonderful topic. I suppose all three of you have got wonderful topics to discuss. So we will be going through the stages of life and how to manage diabetes at different stages of life. Lovely.
I'm already. Yeah.
Can we start?
Vineet?
Yes, we can go ahead.
So shall we start now?
Yes, sir. Yes.
Yes. So good afternoon, everyone. A very warm welcome to each and every speaker, each and every audience. Thanks a lot to the organizers of this scientific feast by RxEvents. And congratulations to all three organizers, those who have come out with their very strong willpower and made this event once more a highly successful event. So a hip hip hooray to each and every one. So with this, today we are going to be here discussing about a very interesting topic, as I was just speaking, that we will be talking about management of diabetes in different stages of life. So my opening batsman is none other than Dr. A. Bhavtarini. Now, Dr. Saab has finished. There is a lot of big list of accolades, what she is, but let me choose certain which may be highly important to you. She's a senior consultant diabetologist at Erode. And along with that, she has her own diabetes care center. She's an honorary professor of diabetes at the State Indian Medical Association. She has been awarded as a Best Teacher Award by Indian Medical Association and also Tamil Nadu State Indian Medical Association Teaching Center for Certificate Training. So today we are at the hands of one. We should all feel very lucky and very proud to have her talking about diabetes diagnosis in early pregnancy. She also has published 12 and presented 18 papers in various national and international journals. She's a participant in 7 clinical trials and is a RIFE member of RSSDI, IMA, API, and Diabetic Association of India. So with this, I hand over the stage to Dr. A. Bhavtarini for opening the innings with diabetes diagnosed in early pregnancy.
Thank you, sir. Can I share my screen?
Yes.
Good morning. Good afternoon, my chairpersons. I immensely thank RSSDA for giving me this wonderful opportunity and also the scientific people. My topic today is Of course, diabetes diagnosed in early pregnancy. When I say diabetes in pregnancy, always my pronouns go to godfather of GDM, Professor Dr. Seshia. You know, if you say early pregnancy, that is a first trimester, the first trimester begins on the first day of last period and lasts until the end of week 12. This means that by the time one knows that she is pregnant, she might already be 5 or 6 weeks of pregnancy. A lot happens during this time of 3 months. In early pregnancy, the embryonic stage begins on the 15th day after conception and continues until about 8th week. During this period, the cells of embryo not only multiply but also take up specific functions, that is tissue differentiation. During this critical period of differentiation, most of the first trimester, the growing fetus is most susceptible for damage from external sources, that is malnutrition, it may be high or low, overnutrition or undernutrition. And today we are going to discuss about the abnormal metabolism.
Sorry to interrupt you, ma'am, but your screen is not visible.
Hello, Dr. Sachin Kathe? Dr. Sachin Kathe? We are live, sir. Please introduce. Yes, you are audible. We are live, sir. Please introduce the speaker.
Yes. Am I audible?
Yes, sir. Audible. Sir, please introduce Dr. Girish Mathur.
Hello.
Yes, sir, you are audible. Please introduce Dr. Girish Mathur.
Okay. Welcome all. So this is the session. We are going to discuss about the complication. So our first speaker is Dr. Girish Mathur. So he is going to present the rheumatological manifestation of diabetes. To know about him, he is a senior consultant, internal medicine, practicing in Kota, Rajasthan. He is a president-elect Association of Physicians of India. He was a past vice dean, Indian College of Physicians, past vice president, Association of Physicians of India, and he's an associate editor of JAPI, a very reputed journal. And he's a recipient of American College of Physicians, Royal College of Physicians, Royal College of Physicians, London, many FRCP. He's
Yes,
a
sir,
member
audible.
of fellow of RxEvents.co.in. And he's also Indian College of Physicians Fellow and Fellow of Diabetes India. So I welcome Dr. Girish Mathur, eminent diabetologist, to present his lecture on rheumatological manifestation of diabetes. Hello.
And Dr. Sanjay Agrawal for giving me this honor to participate in this prestigious event. The subject allotted to me is rheumatological manifestations of diabetes. Diabetes is a systemic disease characterized by hyperglycemia that is both acute and chronic biochemical and anatomical complications which affect various organs and systems of the body. Musculoskeletal system can be affected in various ways in diabetes patients. Pathogenesis of this involvement is diverse and not fully understood. And some of the musculoskeletal complications are related to micro and macrovascular complications and are due to poor glycemic control. The complications are commoner in long-standing type 1 diabetes, but are also seen in type 2 diabetes. The rheumatic manifestations of diabetes are the commonest of all described endocrine rheumatic manifestations. These are under-recognized and poorly treated. These are not only involve joints, but also soft tissues and the bones. These manifestations are closely linked to age, disease duration, vascular complications, and glycemic control. And in contrast to various vascular complications of diabetes, which are life-threatening, these manifestations are not life-threatening, but lead to considerable morbidity. If we talk about pathophysiology, the four mechanisms are suggested. One is abnormality in the connective tissue due to abnormal deposition of connective tissue material and excessive advanced glycation end products, and because of proliferation of myofibroblast. Another mechanism suggested is neurovascular mechanism due to long-standing hyperglycemia in diabetes leading to neuropathic joint disease. The third mechanism suggested is a genetic mechanism because of antigen sharing between diabetes and some genetically linked rheumatic diseases like rheumatoid arthritis. And fourth mechanism suggested is increase or decrease activity of insulin or insulin-like growth factor IGF-1. The insulin increases the production of collagen in general and proteoglycans in cartilage. There are also both insulin and IGF-1 stimulate osteoblast activity. Low IGF-1 level lead to osteopenia and osteoporosis. Metabolic syndrome is associated with increased IGF leading to obesity, which in turn is related to rheumatic conditions like gout and osteoarthritis. If you classify the rheumatological disorders in diabetes, these can be classified by two methods. First is according to the sites involved, and second, whether the disorders are painful or painless. By the first criteria, according to the site of involvement, most commonly sites involved are hand, shoulder, lower limb, and spine. The hand, the disorders commonly seen are carpal tunnel syndrome, Dupuytren's contracture, trigger finger or flexor tenosynovitis, diabetic chiroarthropathy, and limited joint mobility. In the shoulder, it is limited joint mobility and adhesive capsulitis or frozen shoulder and calcific periarthritis. And lower limb, Charcot joint is the common rheumatic manifestations, followed by diabetic muscle infarction in thigh and calf and osteoarthritis of the knee. The spine, the most common disorder is diffuse idiopathic skeletal hyperostosis, commonly known as DISH. By the second criteria, whether the disorders are painful or painless, the painful conditions are carpal tunnel syndrome, diabetic amyotrophy, reflex sympathetic dystrophy, osteoarthritis, diabetic muscular infarction, diffuse idiopathic skeletal hyperstosis, and the painless conditions are Charcot joint, diabetic chiroarthropathy, flexor tenosynovitis, and Dupuytren's contracture. There are other rheumatological disorders which are common in general population and have increased prevalence in diabetic population like carpal tunnel syndrome, gout, osteoarthritis, osteolysis of forefoot, and migratory osteolysis of hip and knee. We will now discuss some individual disorders in some detail. First is a chiroarthropathy, also called as stiff hand syndrome or limited joint mobility syndrome. It is characterized by thick, tight, waxy skin, mainly on the dorsal aspect of the hands, with flexion deformities of the metacarpophalangeal and interphalangeal joints. The pathogenesis involved is there is a dermal and subcutaneous sclerosis secondary to non-enzymatic glycation of collagen with decreased collagen degradation. The limited joint mobility can be shown clinically by the inability of the two palms to come completely together with the wrist maxillary flex forming the prayer sign. Patient cannot oppose his both palms together, and there is in early stages there is paresthesia and slight pain also. The symptoms increases very slowly, and there is a pain aggravated by movements of the hand. This is a prayer sign classically seen in chiroarthropathy. Another sign is tabletop sign. Patient cannot make contact with the tabletop with the palmar surface of the fingers. Biopsy shows thickening of periarticular rather than articular collagen due to non-enzymatic glycosylation of the collagen. It is commonly seen in type 1 diabetes and is a marker of other diabetic vascular complications. There is limited joint mobility and Dupuytren contractures are commonly found in the same patient. Treatment is NSAIDs, physiotherapy, and glycemic control. Another condition is Dupuytren's contracture. It presents with thickening, shortening, fibrosis, and nodule formation of the palmar fascia. Results in flexion contractures of the fingers. In patients with diabetes, the ring and middle finger are more commonly affected compared to the fifth finger in patients without diabetes. The prevalence of this condition in diabetic patients ranges from 20 to 63% compared with 13% in the general population. These contractures are generally milder in diabetics than in patients who do not have diabetes. Treatments again physiotherapy, steroid injection, and surgical intervention in some severe cases. One more important manifestation is carpal tunnel syndrome, otherwise also called as entrapment neuropathy. It's characterized by pain and paresthesia over the median nerve cutaneous distribution of the thumb, index, middle, and lateral half of the ring finger, which is often worse at night. The symptoms are caused by compression of the median nerve within the carpal tunnel, as well as diabetic neuropathy or a combination of both. Or 20% of patients with carpal syndrome have diabetes. It is more common in women than in men. Treatment consists of analgesics, splints, and local steroid injection, and surgery indicated if not response to conservative measures. One more rheumatological disorder commonly seen in diabetes is trigger finger or a flexor tenosynovitis or sclerosing tenosynovitis. It is caused by fibrous tissue proliferation in the tendon sheath, leading to limitation of the normal movement of the tendon. Middle and index finger are most commonly involved. Patients complain of a catching or a locking sensation that may be associated with pain in the affected finger. Examination shows a palpable nodule and thickening along the affected flexor tendon sheath, overlying palmar aspect of the metacarpophalangeal joint. It is associated with the duration of diabetes, but not age. Treatment is corticosteroid injection into the symptomatic flexor and tendon sheath. Other modalities are NSAIDs, splinting, and surgical release. Another common disorder is complex regional pain syndrome. formerly called reflex sympathetic dystrophy or shoulder hand syndrome Sudex atrophy. It is characterized by localized or diffuse pain, usually with swelling, trophic changes, and vasomotor disturbances with impaired mobility of the affected region. The condition may occur spontaneously or after minimal trauma or following surgery or a fracture. Apart from diabetes, other conditions which predispose to reflex sympathetic dystrophy are hyperthyroidism, hyperparathyroidism, and type 4 hyperlipidemia. Treatment includes corticosteroids, muscle relaxant, and intravenous sympathetic blockade, and surgical sympathectomy may also be required in severe cases. One more important rheumatological disorder in diabetes is frozen shoulder or adhesive capsulitis. It is seen twice as common in diabetic patients. It refers to a stiffened glenohumeral joint, usually caused by thickening and contraction of the joint capsule, which results in a substantial decrease in capsular volume capacity. Patients report a shoulder stiffness along with a decreased range of motion and pain. The pain of this condition is less in diabetic patients than that of the general population. Also, it's seen in hyperthyroidism, Addison disease, and Parkinsonism. This is a skygram showing a contracted and adherent joint capsule in the frozen shoulder. The decreased range of motion in this condition is worst in abduction and external rotation, and internal rotation is least affected. Treatment consists of physiotherapy, use of analgesic, steroids, and in severe cases, surgical and arthroscopic capsular release will be required. One important rheumatological disorder of the spine is diffuse idiopathic skeletal hyperostosis or ankylosing hyperostosis, also known as Forster's disease. It is characterized by new bone formation, particularly in the thoracolumbar spine. There is new bone formation around the hips, knees, and wrist also. There is a mild back pain and stiffness, but the range of motion is preserved. It is more common in type 2 diabetes and occurs in 13 to 49% of patients with diabetes and in 1.6 to 13% of otherwise healthy patients. It is also associated with hypermetabolic syndrome, high uric acid, and obesity and dyslipidemia. There is a chronic elevation in insulin and insulin-like growth factors, which facilitates calcification and ossification of ligaments and enthesial regions. These regions are often subjected to increased mechanical stress. These are usually present in contiguous thoracic vertebra, typically described as flowing osteophytes along the anterolateral aspects of the vertebra. There is preservation of the intervertebral disc, an absence of epiphyseal joint degeneration, and absence of sacroiliac inflammatory changes. We can see the new bone formation and the vertebra with the calcification of the anterior ligament and posterior ligament. There is a new bone formation along the vertebra. The ossification of ligaments and tendon sheaths elsewhere may also occur, such as the skull, pelvis, heels, or elbow. A proposed mechanism of causation is the prolonged and high levels of insulin or insulin-like growth factors occurring in diabetic patients, stimulating new bone formation. There is a mild stiffness on arising in the morning, and 16% of affected persons may develop dysphagia. Treatment is analgesics, heat application, physiotherapy, and glycemic control. One more condition is diabetic muscle infarction, also called as tumoriform focal muscular degeneration. It is common in type 1 diabetes with mean duration of 15 years. There is acute onset of muscle pain and swelling, most commonly affecting thigh muscles and calf muscles. A palpable mass is seen in 34 to 44% of patients. The biopsy reveals muscle fiber necrosis, edema, and granulation tissue. Serum creatine kinase level may be elevated in this case. The medical treatment consists of antiplatelets and anti-inflammatory drugs. One common condition in diabetes is Charcot arthropathy, first described in 1868 by Jean Martin Charcot in patients with tabes dorsalis. There is destructive arthropathy in disease which impair sensory function but maintain normal motor function. It is present in 0.1 to 0.4% patients of diabetes and usually in ages of 50 to 69 years of age group. It is most common in metatarsophalangeal joints, tarsometatarsal joint, tarsus, ankle, and interphalangeal joints. There is single painless swollen deformed joints in the setting of peripheral neuropathy. There is periarticular soft tissue loosening, thereby causing joint laxity and subluxation. This is Charcot joint. One more condition is diabetic amyotrophy. It is characterized by muscle weakness and wasting, and by diffuse proximal lower limb muscle pain and asymmetrical loss of tendon jerks. The shoulder girdle may be affected, but less commonly. Typically occurs in older men with type 2 diabetes and is often associated with weight loss, sometimes as much as 40% of pre-morbid body mass. There is significant weight loss in diabetic amyotrophy. Management consists of stabilizing glycemic control and use of physiotherapy. Most cases usually improve, but the improvement is gradual and often incomplete. If you see the prevalence of various rheumatological disorders, adhesive capsulitis of frozen shoulder is the most common, around 11 to 30%, followed by dupuytren's contracture, carpal tunnel syndrome, flexor tenosynovitis, dish, and limited joint mobility. There are some other conditions also which are very prevalent with diabetes, like osteopenia, osteoporosis, osteoarthritis, and gout. Osteoarthritis is a degenerative joint disease. It's most common rheumatic disease in the general population, a group of mechanical abnormalities involving the degradation of joints, including articular cartilage and subchondral bone. It may be asymptomatic or mild, but severe involvement may lead to severe pain, stiffness, and limitation of motion in the affected joints. It involves knees, hips, and spine. Prevalence of osteoarthritis is higher in young and middle-aged diabetic patients. Joint damage starts at an early age and is much more severe in diabetes than in controlled patients. Insulin stimulates cartilage growth. It is also mediated through insulin-like growth factor 1. Treatment consists of NSAIDs, physiotherapy, and a total knee transplant in severe cases. Another important condition is gout. Gout is an acute, as you all know, gout is an acute and chronic arthritis caused by monosodium urate crystal deposition. There are red, tender, hot, swollen joints. Hyperuricemia is an integral part, and it is a type 2 diabetes, also a part of this syndrome. An association of gout and type 2 diabetes is commonly expected. Renal insufficiency is which is a common complication of diabetes, is also predisposes to gout. Whether the diabetes or its complications exacerbate existent gout or affects outcome is not well studied. And then we can say that rheumatological complications related to diabetes are common and can lead to significant morbidity. The long duration of diabetes, especially with poor glycemic control, increases the risk of developing of these conditions. Early identification of characteristic rheumatological manifestations of diabetes may facilitate its management and reduce morbidity. On the other hand, presence of rheumatic manifestations in a diabetic patient can also serve as a marker for poor glycemic control and presence of microvascular complications like diabetic retinopathy. There's a very important saying by Hippocrates: we can cure sometimes, we can treat often, but we can always comfort the suffering humankind. Thank you so much for the patient hearing.
Hello.
Good evening, one and all.
Oh,
Can I start?
so just wait, sir. So our second speaker is eminent Dr. Anand Shankar, sir. He is a founder, chapter secretary of RSSDI in Bihar chapter 2016-19, organizing secretary annual conference RSSDI Bihar, joint secretary Diabetes in Pregnancy Study Group of India, member editorial board Journal of Clinical Diabetology, and he is a chairman membership drive API Bihar from 2015 to 16, and he has authored a chapter in a book on remogliflozin. So he is going to speak on managing infections specific to diabetes mellitus. Over to you, Shankar sir. Please start.
Thank you, Chairperson. Good evening, one and all. Am I audible?
Yes, sir, you are audible.
Okay, I'm sharing my slides. It's visible now.
Yes, yes. Please make it full screen.
Is it now?
Yes, yes.
Thank you. So at the outset, I thanks our president and chairman and organizing secretary and